So in our last video, we talked about the first 6 cranial nerves. Now we're going to talk about the last 6. We'll start with cranial nerve 7. Cranial nerve 7. And this is called your facial nerve. And it's a fitting name because it deals with the muscles of your face. So raising your eyebrows, giving a smile, stuff like that. So right, facial muscles. Not only innervates the facial muscles, but other muscles like the muscle that closes your eyes. To close your eyes. It's a common test in physical exam. Ask the patient to close their eyes. So eyelid closing. And it innervates this muscle that attaches to your stapes, the bone in your ear, called your stapedius. And your stapedius attaches to your stapes. That's why it's called the stapedius. And it stops it from hitting your ear too hard. Kind of dampens it. Dampens stapedius. And if something's wrong with your stapedius or something's wrong with your facial nerve, then you can no longer dampen it. Yeah, so your stapes hits your ear hard all the time. And so any noise is just too loud because it's no longer able to be dampened. It just hits your ear too hard all the time. So we call that hyperacusis. Hyperacusis. That just means you're sensitive to loud noises if something goes wrong. Now when something goes wrong with your facial, now if someone has facial nerve palsy, we automatically think of facial droop, and rightfully so. But I've seen questions where they talk about someone with facial droop and then they ask, what else do you expect to find? And hyperacusis is almost always on there. And people see that and they think, that's hearing. Isn't that cranial nerve 8? Doesn't cranial nerve 8 have to do with hearing? Yes, but never forget that cranial nerve 7 plays a part in hearing also. All right, it dampens the stapes, and if something goes wrong with it, you can no longer dampen it, you get hyperacusis. Another thing it innervates the things that your lacrimal glands, things that help you cry and tear up. So lacrimation also innervates your salivary glands. Which salivary glands? You have a ton of them. All of them except your parotids. You see, your facial nerves actually go through your parotids, and if you have a parotid tumor or a parotid growth, then it can compress your facial nerve, you get facial pain. It goes through your parotids, but it does not innervate. Salivary glands except parotid, and that is very important. That's a common trick question. They'll show you a nice, great picture of the parotids with your facial nerve going right through it, and then ask you, what does it innervate? It does not innervate the parotid. It doesn't innervate the thing that goes right through. Common trick question. All right, so a couple of ways they can trick you. They'll talk about hyperacusis, or they'll talk about the salivary glands. Just remember it doesn't innervate the parotids and should be good. Last but not least, gives you taste in the anterior 2/3 of your tongue. Realize I said taste, not sensation. Those two are not the same thing. You can sense something and not taste anything. You can taste something and not sense anything. They're not the same thing. So it gives taste to your anterior 2/3. What gives sensation? What gives sensation around this area in general? Give me the exact branch. Give me the exact nerve. That'd be trigeminal nerve branch 3, mandibular branch. That gives you the sensation. Every 2/3. Okay? So you gotta know that also. They might be really nitpicky and ask you what branch of the facial nerve gives you that taste. It's your chorda tympani. Chorda tympani. Sometimes they might not even say facial nerve, they might just say chorda tympani does what? Taste to the anterior 2/3 branch of your facial nerve. So these are very nitpicky facts that they can trick you with on questions, but in real clinical practice, when we test for a facial nerve, we do our physical exam, we always test for the facial muscle part of it. We ask them to raise their eyebrows, ask them to give a smile, close their eyelids, stuff like that. And if they have facial droop, then we know something's wrong. Sometimes they can have facial droop in only their lower half of the face. Sometimes they can have facial droop in their whole face. Why is there a difference? What causes that difference? Let's talk about it here. So here's their face, eyebrows, and your cranial nerves, they come out in pairs. Yeah. So your cranial nerve 7 will come out in pairs and innervate your face. And the reason they come out in pairs is because you have two sides of your body. So one innervates one side, one innervates the other. So they come out and they stem from this base. this processing center, this nuclei. All right, so you have your pairs of nuclei. And from that nuclei, your facial nerve will come out and innervate your face. All right, and all that is controlled by your brain, and your brain has two hemispheres, right? So if it wants you to move, then it'll send an impulse to your facial nerve nuclei, and that'll send an impulse down your facial nerve and cause you to move, raise your eyebrow or smile or whatever. Now, let's look at this in a little bit more detail. We said you have two pairs because you have two sides of the face. All right, so we can just split this up into two sides. And we'll look at the right side in more detail. Not only is it split into left and right, but it's also split into up and down. So your nuclei split up to up and down. So up and down. So we can also split the face into up and down. And the upper part of your nuclei will innervate the upper part of your face. That just makes sense. And the lower part of the nuclei will innervate the lower part of your face. Again, nothing too conceptually difficult there. Here's where things get tricky. The upper nuclei gets input from both sides of the brain. Your lower nuclei isn't that lucky. Your lower nuclei only gets input from the contralateral side. And you're saying, well, why is that so difficult to understand? That seems pretty straightforward. What happens if you have an upper motor neuron lesion? What happens if you affect these orange nerves? These are upper motor neurons. Okay? So we'll just look at it one side at a time. We'll look at the right side. What happens if you damage your right hemisphere, your right brain from a stroke? We'll no longer be able to send a signal. Okay? Does that matter? You still have input from your other side, so your upper is fine. You still have input from your lower side, so your lower is fine, and so perfectly all right. Now let's go back to our starting point. Well, if you have a contralateral lesion, something on the other side, something on the left side. So something's wrong here. Something's wrong with your left brain. Well, this will cut the impulse to your upper half. Does that do anything? No, like I said, your upper half gets contribution from both sides, so still gets some contribution, and your upper half is fine. You'll be able to raise your eyebrows. It'll also cut the contribution to your lower half. Will that do anything? Yes. Your lower half only gets singular contribution. So you cut that out, your lower half is shot. All right. You ask them to smile and they won't be able to smile with one of their sides. So I'll write, if you have only lower face palsy, that equals contralateral upper motor neuron lesion. Easy as that. Patient comes in to your clinic, has facial droop, and you ask them to raise their eyebrows, and they can raise their eyebrows just fine. Ask them to smile, and only one side can smile. That's a contralateral lesion. Contralateral upper motor neuron lesion. There you have it. Easy as pie. Now let's reset. Let's see what happens if you have a lower motor neuron lesion. So our lower motor neurons are going to be the actual neurons that innervate your face. So color coordinated, these are going to be your brown nerves. So these are your lower motor neurons. So let's just look at the right side. What happens if your right lower motor neurons are cut? Well, the nerve that was innervating your upper half is gone, so you won't be able to raise your eyebrows. The nerve that was innervating your lower face was gone. Now you won't be able to smile. So nothing works. You have full facial paralysis. So if a patient comes into your clinic and has full facial paralysis, that has an ipsilateral lower motor neuron lesion. That is it. That is your facial nerve. That's quite a lot for just one nerve, right? Well, it doesn't get much better. The next one is going to be cranial nerve 8. Cranial nerve 8 is called your vestibulocochlear. It deals with hearing and balance. So let's draw your head and your ears. And this is how you hear. Vibrations come in through your ears, and it'll hit a series of these bones called your MIS bones, Malleus, Incus, Stapes, MIS. These small little bones that are able to take that vibration and send it to this giant goober called your cochlea. And your cochlea is able to sense that vibration, turn it into a nerve impulse, and send it to your brain to process it as sound. And that is how you hear. Now the culmination of all this whole process we call conductive hearing. Conductive hearing. Why do we call it conductive? Because you're able to conduct those vibrations, send it to your Malleus, Incus, Stapes, send it to your cochlea, and that gives you sound. Now can we isolate parts of this process? Yeah, we can isolate the cochlea. Isolate the cochlea. When we isolate the thing that senses the vibration and sends it out of the nerve, we call that sensory neuro. Hearing. How can we isolate it? Well, we can put a tuning fork to the head, to the back of the mastoid, that's Rinne, to the top of the head, and we call it Weber's. And when we put a tuning fork, let's just say to the head, it'll send vibrations, bypass this part, only hit your cochlea will feel those vibrations and do what it does. Turn it into nerve impulse and send that on its way. And that way we can isolate the sensory neural part of our hearing. So for our intents and purposes, we have two ways of hearing. We have our regular conductive hearing, that's our everyday hearing, and then we have our sensory neural hearing. And by using Weber and Rinne, we can tell if one of these have gone out. So Weber and Rinne is going to be what we're going to talk about today. Weber and Rinne. So let me just draw out the other ear. Just so it's nice and symmetrical. So Weber's test is when you put a tuning fork right in the middle of the head. Right there. What happens if you have conductive hearing loss? Conductive hearing loss. And again, we're going to pick on the right side of the head. So we'll say the right side, you've lost your conductive hearing. You can no longer hear through this pathway. You're no longer able to transmit vibrations through this pathway. So you put the tuning fork right down the head, and it will send vibrations to stimulate your cochlea. On the unaffected ear, your conductive hearing is fine. You're going to hear all this thing. You're going to hear all this background noise. So if you're in a hospital, you'll hear nurses talking, you're going to hear doctors talking, you'll hear machines beeping, all this background noise, as well as the vibrations from the tuning fork. All right, so you're going to hear both. You're going to have a nice mixture of both. Here on the right side, where you've lost your conductive hearing, you won't have any background noise. This is completely silent. This is completely silent. You don't hear anything. The only thing you hear is that tuning fork. It's going to be loud. It's going to be the sole sound you hear in that ear. It's going to be overwhelming. And so when you have conductive loss, it will localize to that ear. So we say localize to affected ear. You've knocked out the background noise, and the only thing you can hear is that vibration. All right, so you have conductive hearing loss, localizes to that ear. Now let's reset. What happens if you have sensory neural loss? Let's talk about the affected side. So the vibrations will hit your cochlea. And then what? Are you going to hear anything? No, your cochlea is what's destroyed. That's your sensory neural hearing. So you're not going to hear anything. So you absolutely do not hear that tuning fork. Let's talk about your unaffected side. Are you going to hear that tuning fork? Yeah, perfectly fine. So it actually localizes to your unaffected ear. Localized to unaffected ear. That's it. That's your Weber's test. Now let's talk about Rinne test. Before we talk about Rinne test, I just want to say we have two ways of hearing. Which one's more sensitive? It's going to be your regular way of hearing. That's why it's our regular way of hearing. We can hear a little mouse peep from 10 yards away. But for us to have sensory neural hearing, we have to put a freaking tuning fork to our skull. That's the only way we can hear it. So this is the more sensitive part of the hearing. So just keep that in mind. So Rinne's test is when you put a tuning fork on your mastoid, buzz, that kind of deals with your sensory neuro. And then when you can no longer hear that buzz, you pull it out and put it in the air. And because your conductive hearing is more sensitive, you will be able to hear it again. All right, so sometimes we call it air to bone. And that's a normal test. That's what should happen because your conductive hearing is more sensitive. All right, so we'll say that's normal. Normal. There's just one problem. You can also have this normal test when you have something wrong with your ear. See, if you have sensory neuro hearing deficits, then you'll also have this normal test. Why? Well, when you put that tuning fork on your mastoid, you won't be able to. It'll send vibrations to your cochlea, but because your cochlea is destroyed, you won't be able to hear anything. So they'll say, do you hear anything? Nope. And they'll bring it to your ear. And because that's perfectly fine, you'll be able to hear it. And you'll say, yeah, I hear it. Isn't that also a normal Rinne test? So you can have a normal test so you can have a normal test if you just have normal ears. You can also have a normal test if you have sensory neuro deficit. And that's why you do the Rinne's first and then you do the Weber to actually see if it actually localizes in. It is abnormal. That's sensory neuro deficit. How about conductive deficit? Conductive. So let's reset. In conductive hearing, you lose this part of the pathway. So you'll put the tuning fork on the mastoid and you'll send the vibration. And you'll hear that vibration. And then it'll stop and you'll move it in the air and say, do you hear it now? So move it in the air. Are you gonna hear anything? Is that pathway existent? No. All right. So sometimes we say that's bone. You hear the bone, but when you put it in the air, you don't hear it. So we'll say that's bone over air. And that is abnormal. That's not what should happen. And you see that abnormal test in conductive hearing loss. That is cranial nerve 8. That's Weber and Rinne. All right, let's move on to cranial nerve 9. Cranial nerve 9 and 10 are very similar. Cranial nerve 9 and 10 help you swallow. So 9 kind of starts it off. It elevates your pharynx, throat, via a muscle called your stylopharyngeal. It also helps you salivate. What's the only gland left? What's the only salivary gland left that we haven't talked about? It'd be your parotid. This is what helps you salivate from your parotid. And also gives sensation and taste to the last part of your tongue, your posterior 1/3. And if that's not enough, it also monitors your baroreceptors. There's a freaking cardiac throwback you didn't think you see. What do your baroreceptors do? They monitor your blood pressure. What are your two main ones? Your aortic and your carotid. Do you remember the baroreceptor that transmits signals to cranial nerve 9, glossopharyngeal? Do you remember? That'd be your carotid. If you said carotids, gold star. That's not how you spell carotid. All right. So that's cranial nerve 9. Cranial nerve 10 is your vagus nerve. That is just one of the biggest, most important nerves. And it does a ton of parasympathetic stuff. It's like the main parasympathetic nerve. So that's your rest and digest nerves. Does a ton of things on your heart, does a ton of things in your GIT. Rest and digest. We're not going to talk about all that. We're mainly going to talk about what it does up here, because we're talking about cranial nerves. What it does up here, again, with cranial nerve 9, it helps you swallow. Helps elevate your soft palate. When you say ah, your soft palate will elevate. That's cranial nerve 10. Elevate soft palate. And the uvula, the little thing that dangles in between. Helps you talk. Helps you cough. One of the ways you can test any palsy of it, ask if they notice hoarseness or ask them to cough, notice any changes in the sound of their cough. Sensory-wise, it provides taste. We literally talked about the entire tongue, didn't we? The anterior 2/3, which was cranial nerve 7, the posterior 1/3, which was cranial nerve 9. What else is there to provide taste for? Well, there's a little bit of taste buds that's past your tongue, almost above your epiglottis, between your tongue and your epiglottis. Okay, and that's cranial nerve 10. Last but not least, it also monitors your baroreceptors. Which one do you think it monitors? There's only one more. It monitors your aortic. Okay. Way you can test this cranial nerve on examination, ask them to say ah, look for their soft palate elevation, make sure that's normal. If it's not normal, we'll say this is your two sides of your soft palate and the thing in the middle is your uvula. This doesn't look right. This looks kind of like a dong, but this is it. All right, and if there's a lesion on your left side, this side, then when you say ah, try to elevate it, it won't be able to elevate. Droop down. Yeah, this side will raise up and this side will droop down. And so the side that has the palsy will droop down because it's no longer being innervated, the muscle's no longer working, and the uvula will keep getting pulled up by the side that is working and it'll turn away from it. All right, so sometimes it says the uvula deviates away from the lesion. And so if it's a problem with your left side, then the left side will droop because the muscle is no longer working, and but the right side will keep pulling and it'll pull the uvula towards it, pull it to the right. Sometimes they say the uvula points away from the lesion, right? So if it's a left lesion, then your left soft palate will droop and your uvula will look to the right. So all right, soft palate, depressed ipsilaterally, and the uvula deviates away. So if it deviates to the right, it's a left lesion. If it deviates to the left, it's a right lesion. Comprende? That should be easy enough. Cranial nerve 11. Cranial nerve 11 is your spinal accessory. The reason it's called your spinal accessory is because it starts from your spine and it actually goes up and makes contact. There's a branch that makes contact with cranial nerve 10. So right, branch with 10. Call that your cranial part of your cranial nerve 11. This innervates your trapezius, innervates your sternocleidomastoid. Your trapezius shrugs your shoulders. If you ever go to the gym and you see people like shrugging their shoulders, they're trying to work out the trapezius. All right, sternocleidomastoid turns your head to the opposite side. So your left one will turn your head to the right. If you ever see someone like really cranking their head, you can see their sternocleidomastoid showing. So that should be an easy way to remember what it does. So it turns your head to the opposite side. Physical examination, ask them to shrug their shoulders. Again, if your left side's affected, then they won't be able to shrug their shoulders. The muscle's not working, so they'll just shrug the right side, and this side won't be able to shrug. And again, if the left side's affected, then their left sternocleidomastoid will be affected. And what does that do? Turn your head to the right, the opposite side. So you ask them to turn their head to the right, and they won't be able to do it. This side's not affected. Your right sternocleidomastoid is not affected. What does your right do? Turn your head to your left. So you'll be able to turn your head to the left. Got it? So all right, traps and SCM, sternocleidomastoid. Last but not least, cranial nerve 12. This deals with all the muscles of your tongue. This is called the hypoglossal nerve. Hypo meaning it starts from underneath your tongue and innervates all the muscles of your tongue. That's why I call it hypoglossal, under the tongue. And all the muscles of your tongue and glossus. The only one that doesn't innervate is palatoglossus, which is not actually part of their tongue, it's actually part of your palate. What innervates your soft palate, that's cranial nerve 10, and that's exactly what innervates your palatal glosses. I don't think you need to know that, but it's just some fun fact. How do you test it on examination? Ask the patient to stick out the tongue. Look for any deviation. It protrudes your tongue, right? And if there's any lesion, then your tongue will deviate. So it'll protrude your tongue. Let me see if I can show it. Protrude your tongue, and if your left side's wonky, your left side has a palsy, then it will no longer be able to protrude it. Yeah? So the left side will no longer be able to protrude. The right side will take over. So it kind of looks like that, and it will point to a lesion. So tongue deviates towards lesion. Tongue to lesion. And that is your cranial nerves. Just a quick review. See if you really were paying attention. We'll do a quick recap on the tongue. The tongue's very complicated because there are different nerves that innervate the tongue. So you have your anterior two-third and your posterior two-third. Is there something that an anatomical landmark that separates it? Yes. There's a line called your terminal sulcus. And there's a hole right in the middle called your foramen cecum. All right. So that separates your posterior one-third and your anterior two-thirds. Now, what innervates your anterior two-thirds? What was taste again? If you said 7, you're right. What was sensation again? Exact branch. Mandibular branch of your trigeminal nerve. Posterior one-third, much easier. Taste and sensation were cranial nerve 9. And then we said kind of past the tongue, between the tongue and the epiglottis, you have cranial nerve 10. Easy peasy. Muscles of the tongue, we literally just talked about cranial nerve 12. So that's just your tongue. Now the recap, let's talk about reflexes. You can do a ton of different reflexes when you're testing cranial nerves. And the reason I like to talk about this is it helps recap what does what. Yeah, when you test a reflex, it actually tests 2 nerves most of the time. I'll show you what I mean. If you test a corneal reflex, this is when you poke the eye and you blink. And that reflex is very important. If something gets in your eye, you automatically blink to kind of protect your eye. So you poke the eye and you blink. When you poke the eye, what senses that? What senses the area up here, including your eye? What branch exactly? The ophthalmic branch of your trigeminal nerve, V1. So you poke the eye and then you blink. What causes you to blink? What causes you to close your eyes? Can you recall? What is it? Cranial nerve 7. Good. Lacrimation. Something pokes your eyes. V1. What causes you to cry? What causes lacrimation? What nerve? 7. Hopefully you're playing along at home, all right? Hopefully you're not just watching this video. If you participate, it makes things stick that much more. Light reflex. Shine light in the eye. What senses that light? Cranial nerve 2. And then your eyes will constrict. What constricts your eye? Cranial nerve 3. Gag reflex. You depress all the way in the posterior one-third of your tongue. And you can sense that. How do you sense that? What causes sensation in the posterior one-third of your tongue? Cranial nerve 9. And then you gag and your soft palate will elevate. What elevates your soft palate? Cranial nerve 10. Good. There's one exception. There's a reflex that only deals with one nerve, and that's your jaw jerk reflex. So hit your jaw and your masseters will close it. So what causes sensation of your jaw, this area? Your mandibular branch, V3. What causes your masseters to close? It's also your V3. All right, so that's just a little bit of recap. That's just kind of a fun way to remember what does what. There's just one more topic I want to talk about. We said that your cranial nerves come from your brainstem, stems from this little processing center called the nuclei. Little processing center, and the nerve will shoot out. That will jut out and go where it needs to go. So if it's your facial nerve, it'll go to your face. If it's your vestibular cochlear nerve, it'll go to your cochlea. And so for the longest time, I thought it would just go from the nuclei, the processing center, to wherever it needs to go and then back. And it's nice and simple. But it's not that simple. So if we take a look at your brainstem, we'll just draw your brainstem really crudely. So here's your midbrain. Here's your pons. Here's your medulla. medulla. Then you have your nucleus. Then I thought that you just have your nucleus center and the nerve would go, but it's not. If you look deep inside the brainstem, then you have these nuclei that kind of zigzag around, and some that are really long, and some that kind of cross over, like really complicated nuclei. And now that I think about it, it should be complicated. The brain's very complicated. Now our last topic is just going to be on the nuclei. Not only are these nuclei, not only do they look complicated, but these nuclei don't just go with one nerve. And they're nice and isolated, so they're all separated. And you have these 12 individual nuclei. No, it doesn't work that way. And it shouldn't work that way, because all our cranial nerves need to work in conjunction. That way I can hear and talk and move my face and see and do all these things at the same time. It needs to work in conjunction. So sometimes we have nuclei that get input from multiple nerves. It helps us synthesize all our information that we need to make our cranial nerves work well. I will take, for example, the vagus nerve, cranial nerve 10. That, we said, does a ton of things. It's your main parasympathetic nerve, so your main rest and digest. Rest, digest, your main parasympathetic nerve. And a lot of parasympathetic things goes to something called your dorsal motor nucleus. Sends parasympathetic signals to your GIT, tells it rest and digest. However, there are some other nucleuses that your vagus nerve can contribute to. How about your nucleus solitarius? This deals with things like your baroreceptors. This deals with things like your taste. So if we take, for example, this, we'll just pretend this is your soleus solitarius. We said that cranial nerve 10 deals with taste, deep taste between your tongue and your supraglottis. So this will definitely contribute to it. However, what else deals with taste? I literally just went over it. Does 7 not deal with taste? Does 9 not deal with taste? So these will also contribute. So you have a nuclei, your nucleus solitarius, that takes input from these 3 nerves. And that way you can coordinate taste all together. Makes perfect sense. There's another nucleus called your nucleus ambiguus, and this deals with the muscles inside of your mouth. So things like swallowing, things like elevating your palate. Swallowing, what do we say helps swallow? Then we say things like 9, 10. The only tricky part is you add cranial nerve 11. And in particular, it's just the cranial part of 11. That's the thing I said kind of contributes to 10, and that helps in that regards. And so that's the nucleus that takes contributions from these 3. All right? And that deals with cranial nerves 1 through 12. Hope you enjoyed the video. Thanks.